Hi guys, welcome to these Smart Bite sessions in obstetrics and gynecology. Today we're going to talk about cesarean scar ectopic pregnancy. Ectopic pregnancy is any pregnancy outside the uterus. It is most commonly in the fallopian tube. It can be in the abdomen or in the ovary, can also be in a cesarean scar. Now, which cesarean scar are we talking? All you gynecologists and the students of MBBS will understand that the abdominal incision, as shown in the first picture here, the abdominal incision on the mother is made vertically or in a fan and steel incision or a low transverse, like we call the fan and steel. It is also called the bikini incision, isn't it? So, just above the pubic symphysis, the low transverse incision is made in the abdomen. Now, that is the most common incision given in the abdomen. Whichever way we enter the abdomen, whether we go vertical or fan and steel, next we reach the uterus. When we reach the uterus, how we open the uterus? As a classical cesarean section, which is a vertical uterine incision, or a transverse incision in the uterus, which is also called the lower segment cesarean section. So that lower segment cesarean section is the most common incision done. Now, the scar ectopic is in the uterine incisions. Don't get confused. Scar endometriosis, when we discuss scar endometriosis, is in the abdominal scars. The scar ectopic is in the uterine scars, and the most common uterine scar is the lower segment cesarean section scar. All right, guys. Talking about this cesarean scar ectopic pregnancy, this is how it looks in the ultrasound, and this is an inverted picture of the uterus on the transvaginal sonography. Let me try and explain this to you a little bit better with the outline. See, the yellow outline is the uterus, and the C is the cavity which is empty. The myometrium is mostly normal. At one place, if you can see here, at one place you can see this red outlined area, which is the cesarean scar ectopic pregnancy. Let me show this even more clearly with the line diagram. You can see in the line diagram that there is a gestation sac in the cesarean scar area. So whoever did this lower segment cesarean section, that place there is an ectopic pregnancy, which is red in color here. So I hope you can understand the anatomy of the cesarean scar ectopic now. And why is the cesarean scar ectopic increasing now? See, the incidence is 0.05%. It is not the rarest. The rarest ectopic pregnancy is still the cervical ectopic, but this is the next rarest. Now, why are we seeing so many of these? This patient which I saw, I am just making these slides, and the next day I saw another cesarean scar ectopic. I have seen 11 cases of cesarean scar ectopic already as a gynecology consultant. I remember in my MD days, my professors in JIPMER, they used to tell me that they had seen one case, anecdotal case of cesarean scar ectopics. Now, what is happening? The increasing incidence of cesareans. Yes, the more number of cesareans we are doing for whatever reasons, that is what is increasing the cesarean scar ectopic. Extremely logical reason. But yes, that's why we say cesarean is not the best method of delivery. Cesarean is a convenient method for the doctor and for the patient, agreed, but it is not the best for the baby. We'll get into this debate some other place, but understand nature has made vaginal delivery the normal method of delivery. And when we alter that, we end up in complications like cesarean scar ectopics. So, yes, when we have the cesarean scar ectopics, they can be endogenic cesarean scar ectopics, which are towards the uterine cavity, and there can be exogenic cesarean scar ectopics, which are growing towards the bladder from the cesarean scar. Now, how do you diagnose this cesarean scar ectopic? If the uterus is empty, the cervix is empty, and the sac is in the uterine scar area. You can see the gestation sac. I'm lining this in yellow. Now, we should also see a layer of myometrium between the gestation sac and the urinary bladder. So, if you see this, this is the myometrial area, and this is the bladder. Bladder is obviously empty when we are doing a transvaginal sonography. That's why I'm not seeing it so well. So between the bladder and the cesarean scar ectopic, you'll see a thin layer of myometrium. That is what is helping us diagnose that it's a scar ectopic pregnancy, and also there'll be increased vascularity in this area. All right. Now remember, sometimes it is very difficult to distinguish a pregnancy which is aborting from a cesarean scar ectopic. Let me explain this. If there is a sac which is in the process of aborting from a uterine pregnancy, the sac is in the process of going through the isthmus, then to the cervical canal and coming out. If you happen to do an ultrasound at that time, you'll see a sac which may look as if it's in the cervicoisthmic area, or it may be in the Caesarean scar also. So what happens that if it is a baby which is coming out of the cervicoischemic area and you push with the transvaginal probe, you'll see the sac will slide up and down. But if it is in the Caesarean scar area, it will not move with the uh, probing of the transvaginal ultrasound. So that's what is known as a negative sliding sign. Okay, I'll try to show this to you here. See this? Yes, I'm probing this Caesarean scar ectopic patient's uterus and I'm moving it, the transvaginal probe, but this sac here is not moving at all. If it was in this area, this is the cervicoischemic area, if it was here, then a sliding sign would have been positive. So negative sliding sign will also help you understand that it's a Caesarean scar ectopic. So what can this patient present to you with? It can present to you with rupture, though it is not very common till late, and it can cause torrential hemorrhage. So it's around 15 to 20 weeks when it is going to rupture, but it's going to be torrential. But sometimes it can continue also in the Caesarean scar and may even give a live pregnancy if it is reaching around 28, 29, 30 weeks. But yes, this is a recipe for a placenta percreta, very difficult to manage. You may end up losing the uterus. The patient will get very sick in those cases. That's why Caesarean scar ectopic should be managed well in time. So yes, what is the management? We can do surgical or medical management. The surgical management is, like we always say, chop off this area and suture the Caesarean scar once again. So go to the Caesarean scar area laparoscopically or laparotomy and remove this Caesarean scar ectopic and resuture at the Caesarean scar. Now that's easier said than done, because when you're trying to make this uterine ischemic resection or transvaginal ischemic resection, the incision is here. Now this area is not easily accessible because it is under the bladder. It is under the bladder. That's why it's not very easy to reach this area. So that's why we say that better than doing a surgical management, go ahead and do the favorite medical management which we do. And the medical management is to use either KCL injection or methotrexate. What I do in my hospital, I do a combination of both these drugs. So yes, I saw 2 cases in 2 days, and we have managed these cases. Last 1 year we've done around 3 cases. Before that, we have done a few. So what has worked for us is that we use KCL, aspirate the fetal tissues, and then put in that sac area some methotrexate. So I'll try to show you all that. So look, this is the first thing. We are trying to put the injection KCL. So you'll see the needle coming from the top of the screen where the ultrasound probe is shown here. So if you see this area now, you'll see, yeah, yeah, see, this needle is just coming in and we have to reach the thoracic area. So we are reaching the thoracic area where the heart is. You can see the fetal heart here. There is some pulsation and we're going to inject the KCL there to stop the fetal heart. So first you assure, yes, see, the KCL is going in now, and this is to assure that there is asystole. And then after that, we aspirate the tissues. We aspirate the fetal tissue. This was around 8.5 weeks of pregnancy, so aspiration was not very easy. So when you are trying to aspirate the tissues with the needle which you're using, generally it's the needle which we use for doing oocyte aspiration. So this is not very broad. They're 17 gauge, 18 gauge needles. But when you aspirate, suppose it's a fetus of around 6 week size, the aspiration will make sure that the fetus is disintegrated and it will not survive in this area. So aspiration also helps. And after the aspiration, we inject. After the aspiration, we inject methotrexate here. See, you can see the fetus is now disintegrated, and now we've injected the methotrexate. This makes sure that all the trophoblastic tissues will eventually degenerate here, because methotrexate will cause the cessation of all rapidly growing cells. So that is one method, and this has worked for most of our patients. And all those postgraduates and gynecologists looking at this should try and manage Caesarean scar ectopics this way. All right. So when we're doing this, after the methotrexate injection into the sac, we also give another methotrexate intramuscularly to this patient. It is around 1 mg per kg body weight methotrexate which we give. So we gave 50 mg into the sac, and we gave around 50 mg into the intramuscular area of this lady into the buttocks we had given, and that makes sure that the tissues will eventually degenerate. So the HCG levels were done on day 4 and then on day 7, and from day 4 to day 7, like always, you should see a 15% reduction in the HCG values. And then you have to do once a week till it is totally negative. It may take around 3 to 4 months also for one of my patients, but she was fine. In fact, the patient I'm talking about 2 years back, we had done this follow up for almost 3 to 4 months, and this patient has now conceived and delivered last year with a cesarean section. Of course, it was done around 36 weeks. So after knowing this, please go back to the basics of ectopic pregnancy. Do read about what is the common site of ectopic pregnancies, what is the timing of rupture of ectopic pregnancies, and what is the relation of ICDs with ectopic pregnancies, whether there's a relation, if at all. Okay, do find time and read this, but just in case you don't find time, here's a quick recall of what I just asked you. So have a look at this chart about the sites of ectopic pregnancy. Remember, the most common site of ectopic is the ampulla. So that is what is the most common site of rupture of ectopic pregnancy also. Ischemic ectopic is not so common. It is 11%, 10 to 11% of the ectopics. It is the earliest to rupture. That is correct. Okay, and the interstitial corneal ectopic is the last to rupture. And remember, when you give IUCDs, the pregnancies numbers will reduce. So ectopics number also reduce. Don't say IUCDs increase ectopic pregnancies. But remember, when you give IUCDs, the patient won't conceive. If at all she conceives, the conception will be in the uterus 95% of time. Only thing, 5% may become ectopics. So there is a relative increase in ectopic pregnancy when you use IUCDs, not an absolute increase. If there is an absolute increase in number of ectopics with IUCDs, nobody's going to use IUCDs, isn't it? We are not stupid that we're going to give ICDs to hundreds and hundreds of women daily basis in the government hospitals if it is going to increase ectopics. All right. So please remember, ICDs will not increase the ectopics. If at all there is an ICD failure, the pregnancy will be in the uterus, and there will be a relative increase of the ectopic pregnancies. All right, guys. So keep coming back to this channel for more updates, more smart bites in obs and gynae, guys. Thank you so much. Good evening.